So, hi, good morning. My name is Mercedes Forero, and today we are going to talk about a little bit about composites. I am a proud member of the dentistry faculty of the University of Universitat Internacional de Catalunya. We've been together for a long time right now, so we are so glad to be part of this project and to share our knowledge with all of you. So I hope this presentation will help you a little bit improve your practice and to become a little bit better dentist. And nowadays, it seems that we live in an opener society, which leads us to be more different from each other every day. But even though we have different ways to be or to think, sometimes we think we're even opposites. I can be sure that there's one thing that all patients that cross our doors office have in common is that they don't want to come back, or at least the less, the better. So actually, most of the treatments that we do in our office, they go really attached to aesthetics. And to know the real meaning of the aesthetics, the aesthetic is that discipline that studies the nature of beauty and the perception of it by individuals. That we have a little enemy, that it is the information and the access that all the patients have to the social media. They have a lot of information, and it makes their expectations to be super high, and we as dentists have to do a labor as educators to them, so that we tell them and we explain to them that the really beauty relies on the natural diversity, and that we're all different, and that even though we can make them their smile better, we can now follow patterns that they see on those pictures. So we have to explain to them, and we have to work on natural outcomes, and we have to work with the materials that allow us to be as more natural as possible. So that's why no matter which material we use, we have to be sure to use it the proper way. We have to be able to correctly select the material we plan to use for each case. And sometimes we have to sacrifice some of the aesthetic outcome for the health. Not all of our patients can afford the all ceramic or zirconia restorations, but the most important thing is that we have to work hard with what we have to get the best result, aesthetically and in terms of health, on oral health. So my conclusion to this introduction is that all the materials are good. We just have to know how and when to use them. And that our main goal in the office should be to keep offering the people the chance to smile again with each and every material. So focusing on the actual guidelines on restorative dentistry, we should start about focusing on the actual guidelines. We should start talking about adhesive dentistry, and actually maybe all the dentistry is based and supported by adhesion. And we can talk about composite. We can't talk about composite without talking about adhesive dentistry. So to start, let's refresh anatomy and the tissues we're working on. We have the enamel, which is the more superficial tissue and is composed by a hard, solid, crystalline structure of hydroxyapatite with strong intermolecular forces. It has high energy surface, water, and organic material. On the other hand, we have dentin, which is a biological composite of hydroxyapatite that surrounds collagen. It's intrinsically humid, has low energy surface and low intermolecular forces, what makes it less hard than the enamel. It's like the enamel, it's like a crystal, it's hard, organized like a web. Underneath the enamel, we have the dentin, which is, as I said, we have the composed by hydroxyapatite surrounded by collagen. So the dentin is more like a sponge in appearance. So here we can see that the enamel is basically hydroxyapatite crystals, and the dentin is, other than the crystals, it's more mainly collagen and water. It's more humid. So the difference between both tissues is evident. And even on the same substrate, we can see differences. On the enamel, there's a specific structural change when it's undergone acid etch. And on dentin, we can see that the tubules in it get wider and nearer when they get nearer to the pulp. So the both tissues are completely different one from each other, and so they are going to work different in the mouth. So dental adhesive have gone through Dental adhesive have gone through a lot of transformations on their chemistry and the number of components within the last 40 years as a result of the challenging pledge to create durable bonding to dentin with resin monomers. Addition to enamel has remained consistently simple and reliable since the introduction of the acid etch by Buonocore in 1955. The formation of the interdigitations into the enamel porosities created by the dissolution of hydroxyapatite with the phosphoric acid is still the crucial mechanism for mechanical bonding of resin-based adhesives to etched enamel. In dentin, the presence of abundant resin tags formed by dental adhesives on the dentinal tubules made us theorize that the mechanical interlocking would work the same way. The problem was the intrinsic humidity of the substrate. Over the last 10 years, that micromechanical mechanism has lost relevance, while chemical ionic bonding has gained prominence. So we used to classify these dental adhesives by generation, but actually it might be better to do it by the way it interacts with the famous smear layer. So as we see, we had a lot of previous generations of the developing of the adhesives, but now we have come to the 8th generation, that it's called the universal adhesives, which are the ones that we are using more commonly today. So there's one product of so we talk about the smear layer, that it's that product that is from the preparation of the tooth, which is called the smear layer. And it is a layer of cutting debris that obstruct the dentinal tubules and create what is called smear plugs that can go from 1 to 10 millimeters in depth. It is known that the presence of smear plugs reduces dentinal permeability in 86%. So depending on the interaction of the adhesive to that surface, we can we have two types of adhesives. We have the group of etch and rinse, and we have the group of self-etch. If we have to remove the smear layer and its appended smear plugs, with the use of acid etch and are called etch and rinse, and those who doesn't use a separate etching step by the introduction of an acidic primer on the composition that transforms that smear layer and including it into the adhesive compound are called the self-etch. So the three steps have on the group of etch and rinse, we have the three steps that have a separate primer and hydrophobic resin bonding. And we have the group of 2 steps that have an hydrophilic solution that serves simultaneously as primer and bonding resin. So with this type of adhesive, we have to etch first, and then we have even 2 bottles or 1 bottle with the primer and the adhesives. In the self-etch group, we can find the 2 steps with the presence of an acidic primer and a hydrophobic bonding on separate bottles, and the 1 step that has it all in 1 bottle. So let's say that actually the golden standard relies on the 3 steps etch and rinse and the selective etching of the enamel when working with self-etching universal adhesives. So the golden standards are or either the 3 steps etch and rinse or the use of universal self-etch, but you doing the selective enamel etching. And what is the universal? What we call universal? The universal is the latest adhesive on the market that works as a self-etch adhesive, but with the recommendation of doing a selective enamel etching. And what is the difference? The difference with a normal self-etch is the presence of a functional and carboxylate monomers that triggers the chemical bonding to the calcium in the hydroxyapatite or even to the zirconia structure. So the benefit of this kind of self-etch adhesives is that it works chemically with the crystals of the enamel. With the universal adhesives, the dryness or moisture of the dentin doesn't seem to be critical. Clinical studies have obtained good results on both, but always when it's rubbed for at least 20 seconds as the manufacturers recommends. The other thing that we have to take in consideration is the presence of water in the composition, needed to ionize the phosphate monomers and trigger the slight decalcification of the hydroxyapatite. For that reason, we should increase the time we spend evaporating the solvent because it's a little bit slower. So leaving behind what we call a little bit like a flow of the adhesive part, let's go into the materials, into the composites. And to do composites, we know that the composite actually is like the ideal material because we can be conservative on the preparation. We can replace the morphology and the mechanical resistance of the natural structure. If we have sealed restorations to prevent secondary caries, pulpulations, and sensitivity, it is biocompatible. We can do long-term restorations. We can achieve natural aesthetic and function. Through the years, and even actually, amalgam gave us all the mechanical benefits of a material, the permanence of these kind of restorations, for sure it's longer than the one achieved with an actual composite. The technique is less sensitive and the behavior is better in a long-term aspect. But we sacrifice the aesthetics, and sometimes on a bigger type of restoration, as we see on the picture, we can sacrifice also the resistance of the enamel and sacrifice a lot of structure. So with composite, we can achieve a good and satisfactory results in terms of mechanical behavior with a better aesthetic outcome. And it's more soft, let's say, with the structure. So what is the composition of the compost? We know that we have an organic matrix, which is the organic phase. We have mineral inorganic fillers, which is the dispersed phase. And we have other components to manage the viscosity controllers, to the tints to do the color, coupling agents, and initiators. So the organic matrix is a mixture of the methacrylates. The most common is the BGMA, and it is a molecule synthesized by Bowen in 1962 that has double reactive carbon bond and at its ends, which give it a bifunctional character. So when polymerizes, creates a three-dimensional polymer matrix. The other common monomer is the UDMA, And the difference between them is that one has aromatic groups on the other secondary amines. The most common used is the BSGMA. Since the monomer have high molecular weight, they incorporate other monomers with low molecular weight as viscosity controllers. In the inorganic fillers, in the dispersed phase, we have inorganic fillers, which it can be quartz, glass, barium, lithium, alumina, and zirconium, crystals of porcelain. And we have pre-polymerized organic fillers that they are going to basically help us on the mechanical properties of the composites. Is like the hard part of the composite. Let's say that the matrix, the organic matrix, is like the liquid one, and the inorganic fillers are the hard one. So the dispersed phase help us increase the mechanical property, increase the fracture resistance, increase the hardness, decrease the polymerization contraction, which is one of the biggest problems of the compo, decrease the thermal expansion coefficient, and decrease the water absorption, which are like the basic common problems of the compo. So going really fast through the classification by size of the particle, we know that we had the macroparticles composite was one of the first ones we had in the market. It has bigger particles, and the mechanical properties were really good, but they caused a little bit of wear on the antagonist and bad polishing, which led to water absorption and discoloration, the adjustment of the margin. So we didn't use it anymore. The next one was the microparticle. So they developed the microparticle to do like the opposite of the macroparticle. But the microparticle, we had highly aesthetics because the particles were really small. But on the contrast, the mechanical resistance was really low. So we basically used the microparticle for the anterior restorations, and we left the macroparticle for the posteriors. So they did a mix of them. So they mixed particles, bigger particles to small particles. So it was good mechanical property. The aesthetics better than the macro, but not as good as the micro particles. So we had the micro hybrid, which were the smaller particles, but mixed with a little bit of more bigger ones. This classification, we used it a lot for a long time. It had good mechanical properties, good polishing, and you could use it for anterior and posterior. But to achieve better results and to have better outcome in long-term restorations, then they developed the nanoparticle, which were nanoparticles, super small, that when they polymerized, they made what we call nanoclusters, which is like a bigger particle. So the strength and the wear were correct. We had excellent aesthetics because the particles were really small, and we could use it for anterior and posteriors. Getting better, they developed the nanohybrids, which is more or less the same. And it's the one that we normally use nowadays. In the basic clinics, now we can have the universal composites. That is the recent evolution of the composite resin technology that includes the biggest advantage of this composite is that they have something that is called color adjustment potential, which the color blends better, and we can match the color better with less syringes and less colors, let's say. So it's more user friendly. So these universal composites are basically nanofillers with the clusters. We have clusters from 4 nanometers to 20 nanometers. To classify the composites by the handling, we have the flowable, packable, or condensable, and now the bulk fills. The flowables, they have low viscosity because due to the decrease in the percentage of fillers and sometimes the addition of substrants, which is a substance surfactant, which is a substance that reduces the superficial tension in order to increase the fluency. They're used to small cavities, class 1 restoration, some class 5s, and more or less the liners. It has less wear resistance, it has less radiopacity and more shrinkage because it's more matrix than fillers, this type of composite. The packable one, the condensable one, has 66 to 70% of fillers, so which is more like condensable. They have, we can make them a little bit more rigid and condensable. It has good physical and optical properties, and is the one we use for all type of restorations at the end of of our works. The book fill, they were thought or they were developed to bring us an easier way to do restoration because the layers can be thicker than with the traditional composite. The increase in depth might be due to the translucency because they have a little bit more translucent particles and a modified matrix. So they started as flowables. We can do layers 4 millimeters. They have good wear resistance, poor optical properties, and less shrinkage. Now we can have them in condensable as well. So we try to use the flowable ones. We use them like as a base of our restorations and to leave the stratification of the more occlusal part with thinner layers of condensable compost, or if we are using condensable bulk fills, then we can fill the entire cavity with it. So knowing the classification and the composition, there's something they all have in common are the problems. And the problems, we know that they have polymerization, shrinkage, the water absorption, and the thermal expansion are the three more common ones. The polymerization shrinkage is caused by the dimensional rearrangement of monomers into polymer chains during polymerization. There's a reduction in the volume of the mass due to decrease in the intermolecular distance. We know about the C factor, which is the ratio of the bonded to unbonded surface area. So we have to take in consideration that we have to do increments, leaving the walls, touching the less walls possible, so that the compound doesn't contract because it has a lot of problems that we are going to talk a little bit later. So the more walls, the more contraction we have. So the stratification can be either horizontal, oblique, or simultaneous. The horizontal, we are going to dismiss it because it touches a lot of walls. Then we can do oblique. The oblique is the first one we used at the beginning of the development of composite, that we did small layers like oblique ones to avoid touching too much walls. But then now we do more like the simultaneous one, which is the one that we do with the bulk fill. We do like the base 4 millimeters depth with the bulk fill, and then we leave just the occlusal part to do it with the condensable. So we use the bulk fill to do this one. There's no correlation between the volume of that and the bone strength of the class 1. So with the bulk fill, we can do like the whole cavity, do it with the same increment, with just one increment, depending on the depth, of course. So the polymerization shrinkage lead us to basically 4 big issues. It can lead us to micro leakage, which can develop secondary caries and discoloration of the restorations. We can have cusp deflection, they can affect the occlusion of the patients. We can have enamel cracks and fractures with the secondary loss of tooth structure, and we can have a gas that can lead us to sensitivity, post-operatory sensitivity. So the water absorption is a second problem, and it's all the materials available absorb water because we are working on a humid environment. The problem with composite is that it affects the internal composition and the properties. So the water assumption leads us to degradation of the resin, increase the surface roughness, we can lead us to discoloration and loss of brightness. Basically, discoloration. So the only way we can avoid the water absorption is during the whole procedure, and it is with a complete isolation of the operating field. Every structure, the thermal expansion is the third problem. Every structure and every material has a coefficient of thermal expansion, and it describes how the size of an object change with the change of temperature. So the tooth are in constant change of the temperature. When that coefficient in the material is different from that on the tooth structure, the result is micro leakage, tooth or material fracture, or an increase in the sensitivity because of the ladders. The ideal material has to match or at least be really close to that of the tooth tissues. So nowadays, the new materials have a similar coefficient to that of the tooth, but we can help ensuring the adhesive process to counter that difference. And even though it is not a problem, there's something we need to know: the elasticity, who plays an important role in the success of the restoration. We need a material resistant to the occlusal loading. So we have that two different modulus in the teeth. The enamel, which is the hard one, has a modulus of 80 gigapascals, and the dentist, the flexible one, has a 14 gigapascals. So both tissues are really different from each other on the elasticity. So we need an ideal material that we have this type of material which is harder, and the amalgam is harder and doesn't have the same elasticity in very large cavities. The one that suffers is the underlaying surface. So since they don't behave the same way under the occlusal loading and under the temperature changes, the hardest remain the same, the weakest one cracks. So going through really fast as well through direct restorations, because we know that you might have experience on them. We are going to go basically on the step-by-step of class 1 and class 2 restorations. So class 1 restorations, we have that, we know that we have the let's say 5 walls, the pulpal one and the vestibular, palatal, mesial, and distal. So what we do basically is we do the isolation, then we do a selective etching of the enamel for 30 seconds. Then we place the universal adhesives. We rub the universal for 20 seconds. And then we place the bulk fill. We do a bigger increment on the bulk fill, and we leave the stratification of the condensable one just 1 millimeter to the occlusal surface. So we do the whole stratification following the cusp and the normal anatomy, and we finish our restoration, maybe having a little bit of tint or makeup, let's say. A class 1 restoration, again, we do we remove the material, we do the selective etching of the enamel, we place our bulk fill, and then we start doing the whole stratification. In this case, we did a little bit of the lingual anatomy, and then we do the polishing and finishing. It's the same, just following the anatomy and doing increments. The class 2 restorations, they to do the class 2, we need a special instruments. We need bands, partial bands. In this case, we use very much the Palonin one, and then we use rings to hold those bands. In this article, Jordi explained us very well a way to do if you don't have like the the rings with the wings that holds the bands, we can do it. In this article, he described how to do it with resin to copy the anatomy that we have to reproduce. So in this case, we do we copy the anatomy first, and we made our ring a little bit more customized, and then we open the cavity, we place the bands, and we do the same the same adhesive step by step. So we did the enamel etching, and then what we do normally on a class 2 is to do first the wall, so that we switch the class 2 to a class 1, and then we fill the cavity as normal as a class 1 restoration. So what we have to do is to make sure that the wedge is properly placed, that the band is in contact with the subjacent tooth, so that the contact point it's really good and tight, and then we remove the band and do the stratification as a normal class 1. Here we can see the same one. We place the rings, we place the mats, the bands, and the wedges. We do the class 1 with our bow fill, and then we finish with the condensable composites doing the stratification, giving a little bit of anatomy with the spatula. We follow the anatomy that we have with the brush. We adjust the edges of the restoration, and then we do the fine finishing and polishing. This type of matrices, I don't know if you have them there, but we use it a lot here. It's called Automatrix, and it gives us a really good access to deeper cavities. The problem with this type of band is that it's a little bit too straight at the end. So we keep this type of bands to do deep margin elevation of a super deep restorations. But with this type of band, we build the floor of that wall 1 millimeter height, and then we change it to the other one, because if we try to do the contact point with these super straight bands, the contact point we are going to leave it a little bit too occlusal, and then the triangle underneath the occlusal, the contact point will be a little bit too big, and then the patient could have food impactation there. So we leave these straight bands just to seal the margin if it's too deep, and then we change it to a round, normal partial metal band, as the Paladin system or the Garrison system, or whatever the systems we have. So this is the type of matrices that we use. So the partial matrix. This is the Paladin, the dense splice system, which have plastic wedges, which are a little bit less aggressive to the gingiva, and with the rings. So we do the cavity, we do the normal isolation, and we place the rings and the band, and we do the step-by-step of our preparation and adhesive protocol. The enamel edge, we place the adhesive, and then we cure it, and we build the interproximal wall first. We remove the band, and then we finish the stratification as a class 1. We make sure that the adaptation of the band in the margins are correct, and that's it. We polish it. We use rubber points and felts with paints to polish the restoration and adjust the occlusion. So, as I said before, I'm always like trying to defend composites against the porcelain, but I'm not competing with porcelain. We all know the difference between them and the advantages in a long term of the porcelain that the porcelain offers us. So what I'm gonna do in my practice in composites, in those cases you consider to do it with. So again, what do we need from a composite? A material that give us the enough strength to resist occlusal loading, that lasts some time maintaining its properties, and that allow us to be conservative on the surface. So what do we need for the anterior restoration, which are the ones that we are talking about? So actually, we have two materials for the anterior treatment. But today we are going to talk about composites. So what are the advantages doing aesthetic restorations, like anterior restorations with composite? The advantages that we can have is that we can be less invasive, we can spend less chair time, it's repairable. This is the only advantage that I really see on composite. It's less expensive, it's less abrasive, and normally it's a simple clinical procedure. This is a little bit like it's not as simple as it seems, but it can be simple. What are the basically disadvantages? That is less resistant. It has the aging, which is the worst part of the composite. So the duration is a little bit short. It needs more maintenance, and it needs manual skills, which is the most important part, that we have to know how to use it so that we have the outcome that we need. So basically, the indications that of the composite is more than proven that it's completely indicated for anterior restorations, all type of anterior restorations. But basically, we have divided the indications in this 5 group of them. So we have the age, we have the dental condition, we have if it's the time that the restoration is going to be in the mouth, the size of the restoration, and the trauma. So in terms of age, we either have or super young patients or super old patients that they don't, I mean, for the younger ones, we can give them, be less aggressive with the tissue and do a composite, and then years after they might change it. And for the older ones, depending on the age, we can do super good restorations that they are going to last years. So to make them not to spend too much money on aesthetics, we can do really good. We can have really good results with composite. The prognosis of the tooth we're working on. In this case, we did a reconstruction to close the diastema, and we used pink composite to mimic the gingiva. And so a year after, we can see how the gingiva has grown over the composite. So doing this type of restoration, then maybe we can be less invasive than to use, in this case, implants or whatever, or to do porcelains. In this case, those teeth were the prognosis was really bad. She's a perio patient, but she wanted something aesthetic, so the tooth, they became bigger, and she had a super big smile, but she was super happy with the results, because she like, what she didn't want was that shape, or like perio patient, no? So we did that, and she was really happy. She didn't spend too much money on them, and the time they are going to strengthen, then she hasn't spent that money. She knew they were for extraction. Transitional restorations, even for ortho, this patient went to the clinic, and they wanted to give this tooth the correct width and length, so that the ortho clinic placed them in position, or the temporary for the implants or whatever we can do with composite, if it has to be in the mouth, a medium term restoration. The size, I'm not gonna place a veneer to correct that micro angle on the incisal edge of the central. We do a little bit of composite and we correct those small details. In this case as well, this is a dentist. He was a student of the university. He wanted to fix that super tiny little diastema and the length of the central incisor. So we did it with compo instead of doing two veneers. A trauma because of the immediate resolution of the problem, of the aesthetic problem. Sometimes with the trauma, we have to wait until we see how is the evolution of the trauma. So we do restorations, even they can be temporary or the definitives, but we give the patient the right to be so that they can smile again while we wait for the evolution of the trauma. So talking about the composites, the material per se, we have a lot of brands in the market. We have with less masses or more masses on dentin masses and enamel masses. We have a lot of materials, but what do we need? What do we really need from a material? We need them to help us imitate the anatomy, and what we have to train, and we have to train our eyes to do so. So we need the material, but we need our eyes to do and to see what we need from them. And what we need is a color. What we need is a material that can match the color of the surfaces. So that's why we have to work on materials that can give us the properties in terms of color of the enamel and the dentin. So since we want to reproduce the tooth tissue, let's have this clear. We have three tissues in our crown. We have on the external layer the enamel, which is clearly thicker on the incisal edge, and it gets thinner while it gets to the gingival third. Contrary to this, we have the dentin, that is the tissue underneath the last one. Then it's thicker on the gingival third, and it gets thinner and also disappears on the incisal edge. And then we have the pulp. The pulp for this type of restoration, it's not as important. So in terms of macroanatomy, we talk about the contour. The contour, which is the external margin of the vestibular surface, and it gives us the length and exact width of it. In the vestibular surface, we have two lines that we call transitional lines, and they divide in three the surface, the vestibular surface. One bigger, the bigger is the one central, and two smaller surfaces are the ones on the sides. Those lines are the border of those areas, and they give us basically the shape of the tooth. It's like the tridimensional aspect of the vestibular surface. Internally, we know that we have three mamelons of dentin. The mesial is the thinner and the longest one. The middle is the one that is like middle, it's in the middle of the two. And then we have the distal one, which is wider and shorter. And that's why normally the distal angles are the incisal edges are a little bit rounder than the mesial one. So normally the mesial angle is a little bit more acute, and the distals are a little bit rounder, and it goes like a little bit to the gingival, like upper. So those transitional lines give us basically three types of shapes of the tooth. We have the rectangular or square, we see that those transitional lines are a little bit parallel in between them. We have triangular surfaces when the transitional lines are a little bit more narrow in the gingival third, and they go like getting more separate or more distant in between to the incisal edges. And then we have the rounder or ovoid surface, where we can see the transitional lines a little bit more near on the gingival third. They get a little bit more apart on the medial, and then they get again a little bit more narrow on the incisal third. So the appearance of that surface is a little bit more round. In terms of microanatomy, the most important thing that we have to take in consideration is the perikymata. The perikymata is the incremental growth lines that appears on the surface of the tooth, of the enamel, basically, as a series of linear grooves. So that's the most important detail that we have to take in consideration of the vestibular surface, and it is typical from young enamel, which is not wear, because with age, those perikymatas get like erased by the wear of the brushing the teeth, eating, or whatever. So we have the young enamel with a lot of perikymatas, and then we know that the adult enamel, for example, is more like polished the surface. And then we have the old enamel, which is super polished or even touched by the dentist, the previous dentist that we can see. So talking about the color, and we're going to go super quick for the colors. The components, basically the components are the hue, the chroma, the value, translucency, opalescence, and fluorescence. The three bases are the hue, which is the name of the color, and then in dentistry we have the beta shade guide give us four basic groups, which are the A, the B's, the C, and the D's. And it's the color, the number of the name of the color is belongs to the dentin, the body of the tooth. Then we have the chroma. The chroma is the intensity of that color, and in the pureness, it is the pureness or intensity. And in the beta shade, we have like four groups as well, and the one give us less chroma, which is whiter, and the four is more chroma, which is more yellow dark. And it depends on the dentin thickness, and that when we see areas with the thicker dentin, it'll be with more chroma, and while we go to the incisal edge where the dentin is a little bit thinner and the enamel is a little bit thicker, then it goes diminishing that chroma. So we have less chroma on the medium third, and we have more chroma on the gingival third. And the value is the amount of white in a color or the light in a color. And we can only see that on black and white pictures. So it is inherent to the enamel. The enamel is like, we call it like color changer. The enamel is like the affects the width of the enamel can let the color of the dentin underneath to go through the enamel, and we can see it. But if the enamel is thicker and the dentin is thinner, then we can only see the enamel. So it might be a little bit more white because the enamel is like has this milky appearance. The translucency, it is inherent to the enamel, and we call it like the color modifier, because the translucency is the capacity of an object to letting the light to go through it. It gives us the milky appearance of the surface in terms of enamel talking. It also works as a color modifier because depending on it, we can see the color of the dentin. So since we want to reproduce tooth tissue, let's have this clear. Again, we have the external layer, which is clearly thicker on the incisal edge, and it gets thinner while it gets to the gingival third. And contrary to this, the dentin, that is the tissue that is underneath, is thicker on the gingival third, and it gets thinner and also disappears on the incisal third. So normally on the halo, we see just enamel normally. So the translucency, it is responsible for one of our the challenges, which is the translucency of the incisal edge. The opalescence is the capacity of an object of letting the short waves to hit the surface and to show us blue reflexes, and the long ones to go through the object and show us orange ones. And the name comes from the opal. So it is inherent to the halo of the restorations, and we need to be able to reproduce that. And the fluorescence is a phenomenon through which those short waves, invisible to our eyes under a specific light, turn into visible ones. So it makes the surface to be brighter under daylight. So the fluorescence, we have a specific fluorescence on our surface, and it's different from one to each other, but we also have different and a lot of different fluorescence on the materials. So we have to take this in consideration when we do restorations, and even though we match the color, if that composite is not fluorescent and the surface of the patient is fluorescent, they might see it a little bit grayish. So it is important, even though this is a porcelain case, this is a patient that came to change those crowns, and we did a BOPT treatment. We did a vertical preparations to mask the color of that dark root. And even though they seem perfect, the patient was super happy with the result. Sometimes when I saw her talking, I saw that they were gray, and we did a lot of tries. And since it was a dark substrate, we chose to use zirconia, and I didn't realize my mistake, and I didn't realize that the zirconia has zero fluorescence. So when I saw her, I was like, what's the problem? What's the problem? It is the color, but it's not the color. They went gray when she talked. If she was with the light of the sunlight in the back, I saw them correctly, but then when she turned and the light hit the surface, they went kind of gray. It was crazy for me. So when I got the hint that it was the fluorescence of those, she didn't want to change them again. She was super happy. She didn't see the difference. That's something that we see, but we have to take it in consideration that it is important that if we see something that it's grayish, but the color is kind of correct, it might be the fluorescence. So how do we do the color selection on composite on anterior restorations? We use something that we call the bottom technique, and we place masses of dentin on the gingival third, the colors that we guess that is the correct, and then we place masses of enamel near the incisal edge so that we can reproduce the translucency of the incisal edge, and then we decide which one is important. It is important to take pictures, a lot of pictures, and to place them in black and white, and if you have polarized filters, to use the polarized filters to see the characterizations of the surface, and we decide which color is that we are going to use. We take normal flashes, pictures with the flashes, we do the black and whites, and we do the polarized. The fluorescence, how can we do the test of the fluorescence with a lamp, the verification of UV lamp? That they are, we have small, I know we have a lot of those to check nowadays with Invisaligns to remove the attaches of the Invisalign. Most of the hygienists, they have this type of lamps to see where the compo is. So we take the patient to a dark room, and then we can see the fluorescence on the patient. We have to be careful, super careful, to select the color because before the dehydration of the patient. Some patients have the surface that gets really super fast dehydrated, and it gets wider. So we have to take the color before taking the pictures, before doing the isolation, before anything. We have to take the color because the dehydration might change the appreciation of it. we shouldn't take the color under a complete isolation because of this, of the dehydration. We have to take in consideration that the thicker the composite, they might change the color, and more if it's the enamel. So we have to really know our composite and the composite we're using, and to know the correct thickness that we use them to have the correct outcome. Once we do this bottom technique to select the color, make sure to cure it because with the polymerization, the color changes. This is the same composite, cured and uncured, and we see a difference in color. So make sure that we cure the compo for the test so that we match really good the compo. So how do we do the restorations? And I'm going to be super fast because we have a lot of pictures and we have to finish this. So we do a wax up with wax on a cast model. We can do a direct mock-up on the mouth, and then we take an index from it and then we remove it. Or nowadays we can do it digitally guided. So how do we do? With a wax up, we have the patient, we take an impression, and we prepare our wax up. So in this case, this girl had this class 4 restoration, and we took an impression, we did the wax up, and then we do the whole restoration being guided by that wax up. We took an index from silicone key from that wax up, and then we removed the composite that she had. We did our adhesive protocol, and we started doing our reconstruction, starting from the palatal shell, and then we placed the dentin. We did a little bit of makeup with intensives, and we replaced the enamel. So for the polishing and finishing, we marked the macro anatomy, and then we did the micro anatomy, and we checked all, and we polished everything with disc and polishing paste. So with this technique, we check that the micro anatomy is correct, and then we do the final pictures. And this is the outcome of the restoration with the wax up, with the previous wax up. How do we do with a direct mock-up? This patient came from ortho. She finished ortho and she wanted to give a little bit of better shape to those tooth. So we did without any kind of adhesive. We placed with the surface dry. We placed the compo and we did the stratification directly on the mouth. We polished the palatal and adjust the occlusion. And then over this, we took the silicone key. Once we took the silicone key, we remove that compo on adhere compo, and we selected the color, and we took the pictures, and we did our stratification sequence. So we followed perfectly the color selection that we did. But since we have here this kind of surface gets super dry and super white while it is under absolute isolation. So we trusted our color selection, and for the dehydration, see how the difference between the incisal edges and the surface it is. But we waited for 1 week, and this is the outcome 1 week after the restorations. So this appointment, we give an appointment 1 week later so that we either correct or just polish the restoration. So we did the polishing protocol in this case, and we had the outcome. And this is the before and after. And digitally is the same. The patient came, we scanned the patient, and he wanted to change to clean those white spots that the ortho left, and to do the class 4. So we did the cleaning, we scanned, and we did the planification on digitally, the wax up, we did it digitally. We do the impression of the model, and we took the silicone key, regular silicone key from that model. So we selected the color. In this case, we used the composite HRI from Mycerium, and we do the preparation. We did the bevel, the adjustment of the silicone key, our adhesive protocol, the palatal wall, the stratification of the incisal edge. We placed a little bit of transparent compo, and we did the vestibular surface with enamel. And then we did the whole polishing sequence. At the end of this presentation, you'll see the whole sequence. We did the whole sequence, and this is the outcome. So we have the immediate post-op picture, and then 1 week later, the control. And this is the final outcome. This is him at the beginning and then at the end with the reconstruction done and the white spots removed. So the stratification, what we do, basically, we have to take into consideration that the enamel, both layers, the palatal one and the vestibular one, they might be super thinner than the natural enamel. We have to be careful with the dentin, and the dentin is the one that is going to give us the color of the restoration. So we have to match the color of the dentin because the enamel will work only as a color modifier, remember that. And then for the incisal edge and to do the halo, we have to place a transparent compo. In this case, in most of the cases, we use this compo that is called OBN, it's called opalescent blue natural, then from Mysterium as well. And it gives us that bluish natural looking of the incisal edge, grayish looking something. So going fast through cases, a little bit of cases, we have these incisal edges, post-ortho as well. She was a super bruxist patient, so she wanted to give a little bit more round the incisal edges. So we did the bleaching, and we did this case, we did it with Emperor Direct. So we did wax up. We did the isolation, the preparation of the surface, the acid edge and the adhesive, and then we checked the silicone key, and we started our restorations with the palatal wall, the increments of the dentin. We followed the other surfaces. We closed a tiny little diastema on this lateral with the partial bands, following the same stratification, and then we placed the vestibular one. We polished the first polishment, and we left it like that. So she came after 1 week to do the final polishing and the final adjustment, and this is the outcome at the first visit. So this is Sonia at the end of the visit, and this is a 2-month control restoration. So this is Sonia at the end. So we gave her a little bit more natural looking to those wear surfaces. A veneer is a super complicated case, but this patient was an orthodontist, friend of a friend of mine. So she asked to repeat composite veneer. She had a previous composite veneer, so she wanted composite veneer. So we did the composite veneer. We selected the color. We did the color mapping. So we did the color mapping, and we selected the color. We took the pictures to see the texture, the color, the value. We did the wax up. We removed what she had, which was class 4 at the end, but they did a veneer, so we had to do a veneer. We took the silicone key. We did the complete isolation and followed the whole protocol again, the same protocol: adhesive, acid edge, adhesive, palatal wall, and then we started. With the stratification of the dentin. We placed the OBN, which is a transparent one. The picture, the lower one at the left, that's the transparent one. We filled that space in the incisal edge with the transparent, and then we followed with the vestibular enamel layer and the application of glycerin to block the uninhibited oxygen surface layer. So this is the final outcome at the first visit. And then this is the pre-polishing that we did for the first visit, and this is the final polishing we did at the first visit. So we did this, we followed this protocol. We did with an endozebra, we marked the mamelons, then with a diamond burr, we marked a little bit of microanatomy that she had. She didn't have too much microanatomy, so we did a little bit of microanatomy. And then with the soft flex discs, we do the macroanatomy, and we do correct the incisal edge if we have any discomfort with it. And then we used astro brush to give brightness. With the enhance, we mark a little bit more the microanatomy on the mamelons in the vestibular, and then we used the polishing system of this composite, which has three polishing pastes, different polishing pastes. So this is the outcome of the patient, and this is the before and the after of the veneer. And this is Marion at the end. And the index technique is a technique that was described a few years ago, but the good thing is that we have a previous workshop. We take a transparent silicone key, and then we can start doing restorations with like stamping, like we fill the surface with the compound, we place it in the mouth, and then we cure it through the silicone key, and it gets cured. So with this type of technique, what we have to do is we have to do one tooth and leave the tooth that is next to it without doing it. We can do one, we do one and we don't do the other one. So that way we can polish the interproximal areas. It is not as simple for me as it seems, but it's good to do bigger restorations and in cases like this kind of where that it's kind of complicated to do them freehand. So this way we have the definitive restorations and we polish them, so we can go from this the before and after of these three restorations. So for finishing and polishing, since we want to reproduce the tooth tissue, we have to on the external layer we have on the anatomy, we have the length and the width of the surface. We know that they might be around, the centros might be around 10 millimeters to 12, 11 and a half. And on the width, it might be from 8 to 9 or so. So the basic important thing is that they might be the proportion might be the 80%, the width of the length. The golden proportion, have to take in consideration the golden proportion, which is if we take in a frontal view, if we take the mesiodistal distance of the lateral, then we increase the central is 1.618, and the canine might be 0.618. So in a frontal view, taking the distance, the mesiodistals of the lateral, the central might be a little bit wider and the canine might be a little bit narrower. And this rule that I like it really much in terms of aesthetic in the anterior tooth, we know that the centros must be symmetric in between. They might be exact, both centros, to let the eye to recognize that the restoration is okay. On the laterals, in the contrary, we can have a little bit difference in between, because since they are getting like turning to the distal area of the mouth, we cannot really see the difference because you have to turn your head so that you can see the difference in between. So we call them fantasy. And the canines, the point of the canine give us a little bit like a personality, no? If it's sharper, it's more like an aggressive smile, and if it's rounder, it's more like a romantic, I don't know, maybe more feminine smile. So it is important to follow these rules. So the sequence of the polishing is basically this one. We have to always see the restorations from in the incisal edge so that we can see the width, vestibularly talking, that we have to reduce or not. Then with disc, we do the macroanatomy, and the macroanatomy is the incisal edge, to polish the incisal edge if it's too long, or give it like the round edges of the angles. Then when we have the incisal edge correctly positioned, then we mark the transitional lines and we work on them. To make them wider, to make them more gingivally, let's say, we use this type of a super thin on course red, the burr, to go in between the papilla, let's say, and reduce the area there so that we can give more like triangular appearance of that area. And then with an endo-C, an endo-C is the burr that we use for endodontic treatment, those burrs that the endo doctor throws away because it's too wear. That's the one that we are going to use to polish the vestibular surface of the compo, because the pattern that it leaves, it's really enamel alike a little bit. So we use the endo-C to mark, even to give like the shape of the vestibular surface, and to mark the mamelons. So we have the transitional lines correctly positioned, and then we draw the mamelons, whatever we need to do the mamelons. In the laterals, normally, even though there are three, we have like one big depression in the middle. So on that depression, we go with the endo-Z and to give a little bit of wear there. And with these cups, silicone cups, we make like that surface even. We smoothen the surface with this type of burr, and then in this way we can see the lateral with the mamelons and the surface. We do the microanatomy with a diamond burr with a thicker grain, super slow speed. We mark horizontally the super tiny little lines, and then we smooth the surface again with the enhance, and then we go to with the paste. In this case, to how do we say, to take the pictures and to do the whole case, we did mark the microanatomy and the perikimatas, even though the surface of these tooth were super polished and smooth. But we wanted to show you how we do the microanatomy and how do we go step by step doing it. So in this case, we marked the microanatomy and we finish in polishing to give it a little bit more natural looking on the lights. The pictures are important because the reflection of the light is the one that is going to give us if the surface is okay, the shape is okay, and the roughness of the surface. So it is important for you to work with cameras in terms of aesthetics. So I believe that this is it. I hope that this time we spent preparing this and the all the good vibes that we give you in this particular presentation help you on your development of your career. My name is again Mercedes Forero, and I'm on the Universidad Internacional de Cataluña, and we are really pleased to be in contact with you and to help you. If there's anything we can do extra, Dr. Akram, I'm sure Dr. Akram will be in contact with us so that we see if we can follow you on your expectations. So again, from Barcelona, with all our good vibes, thank you so much, and I hope that you enjoyed and that you learned a little bit less from this presentation.